But, let me thank the organizers for the invitation, Dr. Sriram Mahadevan in particular, and Dr. Krishna Sheshadri. So in the next 15 to 20 minutes, I'll be talking on PCOS, a little bit about pathophysiology, what are the reasons why do you get sub-fertility. The treatment options, I'll be only dealing with the oral ones. I will not deal with the gonadotropins thing because we don't do that often. So polycystic ovary syndrome is the predominant cause of anovulatory infertility. It affects up to 10% of premenopausal women. Up to 44% of unexplained infertility cases demonstrate polycystic ovary morphology on ultrasound. PCOS contributing to infertility in 21% of couples with ovulatory dysfunction point to a defect in endometrial receptivity. So this is the diagnostic criteria for PCOS. You had the NIH, the Rotterdam, and the Androgen X is PCOS Society classification. So what's important in all of them is, the most important factor is increase in androgens, either clinical or biochemical. And then menstrual history of oligo or anovulation. So this is also very important. So the NIH only included this, clinical or biochemical and menstrual history. The Rotterdam, 2 out of the 3. In addition, they wanted ovarian appearance, size and morphology and ultrasound. So 2 out of 3, if it is present, it's enough. The AEP PCOS Society was almost a mixture of this. So it's characterized by disordered gonadotropin secretion, hyperandrogenemia, insulin resistance and hyperinsulinemia, ovarian dysfunction, and follicular arrest. So the most important thing is consistent feature is increase in androgens. So what is the reason for all these things? So you have an abnormal gonadotropin pulse generator. Normally, if you have a slow pulse, it stimulates FSH. If you have an increased pulse, that is 1 per minute, it stimulates LH. So you have more of a rapid pulse, so which stimulates LH. LH, as you know, will stimulate the 17-alpha hydroxylase, 1720 lyase, and stimulate androgen production. Now, when you have more androgen production, it impairs follicular development. Also, because of the increase in LH, you also have reduced FSH, which is required for follicular development. And then similarly, there is an insensitivity of the estrogen progesterone on the hypothalamus, so the pulse generator is more active. Furthermore, it's acted upon by obesity, hyperinsulinemia, other factors leading all to this complex condition. How insulin resistance produces hyperandrogenemia? So one, it can produce increase in GnRH release. It also increases the adrenal production of androgen. Insulin can reduce the SHBG, sex hormone binding globulin. It can increase the ovarian production of androgens. Now we say insulin resistant, then why is it working more? So we call this as a selective insulin resistance. So selective insulin resistance means it is not acting at where it should have acted. The main action of insulin is glucose disposal. It is not acting there well, and it is acting at unwanted places. So normally what happens is you require that insulin signaling to happen, but that's not happening. So you have an hypothesis known as a serine phosphorylation hypothesis. Now, what is this serine phosphorylation? Insulin, when it binds to the receptor, undergoes what is known as autophosphorylation. Then downstream mediators get activated. And then finally, the action of insulin also should come to an end. And now this comes to an end by what is known as serine phosphorylation. So here there is an activation of serine phosphorylation. So its main action will come to an end. That is the glucose disposal, GLUT4 upregulation, all these things will come to an end. But the same serine phosphorylation can actually produce hyperandrogenemia. So it can stimulate the 17-alpha hydroxylase 1720 lyase enzyme, and there's an hyperactivation of this because of this serine phosphorylation. So the main action of insulin comes down, whereas the action which is not required will increase. So you can see here. So this is an unwanted pathway. So insulin will stimulate the mitogenic action. It can also stimulate via this enzyme, the CYP11A1, 17A1, 19A1, leads to excess of steroidogenesis. It's not mandatory you should always have hyperinsulinemia. Sometimes hyperandrogenemia can also lead to hyperinsulinemia. So this can happen, mainly they saw in transgender who are given testosterone, female to male transfer. When they were given testosterone, they found that there are some hyperinsulinemia. So the mechanism include upregulation of the beta-3 adrenergic receptors and hormone-sensitive lipase expression in the visceral adipose tissue, increase lipolytic activity and release of free fatty acid into the circulation. And this can also activate the PKC and inhibition of insulin signaling. Furthermore, it can also produce what is known as decrease the amount of type 1 muscle fibers, which are insulin sensitive, and increase type 2, which are actually insulin resistant. So in a nutshell, how this happens, so you have GnRH pulses which are rapid, you have an altered LH-FSH ratio, so you have an ovarian theca cell androgen production, decreased granular cell aromatization, hyperandrogenism. Hyperandrogenism in addition via increased NEFA, increased type 2 can lead to hyperinsulinemia. This can lead to GnRH pulse, so it's a vicious cycle, and hyperinsulinemia per se can also lead to selective insulin resistance, increased androgen production, reduced SHBG production, so it's a vicious cycle. So there's a minimal model hypothesis where the most important contribution is functional ovarian hyperandrogenism. The other contributors include insulin resistance, hyperinsulinemia. The third is the LH excess, and then finally the decrease in FSH is the fourth one. Now coming to why do you have disordered follicular genesis? The follicle development is actually regulated by delicate equilibrium between extra and intra-ovarian factors. So this gets disturbed, then it can compromise follicular development and abnormal oocyte maturation leading to infertility. So in PCO, what happens is you have a decreased FSH, increased LH, hyperandrogenism, hyperinsulinemia. Intra-ovarian factors like growth factors, cytokines, homocysteine, leptin, oxidative stress. So they all lead to follicular alteration, oocyte abnormalities, and poor embryo quality. So one of the important factors I told you was hypersecretion of LH. Now what does this do? You require a small amount of androgens for a proper follicular development. But when it is in excess, it produces early luteinization of granulosa cell. So once this happens, it leads to arrest of the antral follicles. And furthermore, it can activate the premature meiotic process that damage oocyte quality and lead to formation of embryonic aneuploidies. So normally you can see here, at 10 mm actually of the follicle size, you find that the LH, the luteinization actually happens. Whereas in polycystic ovaries, it happens at 5 mm itself, and further growth gets retarded. The terminal differentiation does not happen. What are the intra-ovarian factors? Kisspeptin has been found on ovaries. They can lead to altered dopaminergic and opioid tone. And similarly, epidermal growth factors are also higher in the follicular fluid. So in PCOS, this EGF may inhibit granulosa cell estrogen synthesis, leading to arrest of follicles. Similarly, you have the IGF, the neurotropin growth factors, these are all increased. Similarly, VEGF is also increased. Now this increase in VEGF is responsible for the increase in ovarian volume you find in patients with PCOS. That's why you find all patients having an ovarian volume more than 10. It's because of this. It plays a role in angiogenesis, follicular vascularization, and intrafollicular oxygenation. There's also an increased concentration of TNF alpha, which is inversely correlated with concentration of estradiol, which is an indicator of poor oocyte and embryo quality. Now coming to the treatment, lifestyle modification and pharmacological. So among the pharmacological one, clomiphene citrate is the first line agent for the induction of ovulation. It's made up of two isomers, N-clomiphene and Zu-clomiphene. It's more potent. It resembles estrogen, so it acts by blocking the estrogen receptor in the hypothalamus, so which leads to pulsatile release of gonadotropin releasing hormone, which in turn releases FSH. So it's used in the dose of 50 to 150 milligram per day for 5 days. If ovulation is achieved, there's no need to increase the dose in subsequent cycles. So you have an ovulatory response of has been achieved in 46% on 50 milligram, additional 21% in 100, and an additional 8% when you increase the dose to 150 milligram. So what you find is it will restore ovulation in 75%, but pregnancy rates are only 35 to 40%. So this differential is because it has a hostile effect on the cervical mucus. So because of this, you find though they ovulate, they may not become pregnant. Approximately 25% may fail to induce ovulation with the maximal doses, or failure to conceive following 6 ovulatory cycle. We call this as clomiphene resistance. More common in obese, somebody who's having a very high serum androgen, hyperinsulinic, or who are having a very high LH concentration. So overall pregnancy rate is 36%, miscarriage rate of 20%. Multiple pregnancy can happen in 8 to 13%. 25% of the clomiphene citrate starters may have a singleton live birth. Side effects: hot flushes, ovarian hyperstimulation, abdominal distension, visual disturbance. Now this is coming after the landmark trial which came in the New England Journal. Aromatase inhibitors are coming in more, they are being more often used. These are non-steroidal compounds, potent suppressor of estrogen synthesis, blocking the action of the enzyme. So because of this transient lowering, there is a temporary release. This estrogen lowering effect causes the hypothalamus, the negative effect is lost, and which produces release of FSH. Unlike clomiphene, they have no effect on estrogen receptors, so there is no deleterious effect on cervical mucus or endometrium. Do not block hypothalamic estrogen receptors, therefore the negative feedback is intact. So there is a coordinated, regulated release of FSH when you use letrozole, and hence you have a lesser incidence of multiple follicle development. Half-life is also lesser compared with that of clomiphene citrate. So doses used 2.5 to 5 milligram for 5 days, starting day 2, 3, 4, 5. The only concern is teratogenicity, increased incidence of locomotor and cardiac abnormalities in infant. So there was one study, which a multi-center study conducted by the Reproductive Medicine Network of letrozole versus clomiphene. And in this, they showed a 44% improvement in live birth rate with letrozole over clomiphene. And moreover, the best benefit or the greatest benefit was in the obese group, although one tertile analysis trended towards benefit of letrozole over clomiphene in all the weight classes. So this was that study published in 2014, letrozole versus clomiphene for infertility in the PCO. So you can see in all patients, the A chart says letrozole is more beneficial, and then when they did a tertile analysis, most important benefit went to persons who had a BMI more than 30, though others also did get benefit. So the conclusion from this study was, as compared with clomiphene, letrozole was associated with higher live birth. Totally they had around 103 live births out of 374 patients versus around 72 in the clomiphene citrate. These studies have been replicated further with letrozole. Letrozole also offers a higher per cycle and cumulative ovulation rate than clomiphene. And in the previous study, only 10% failed to ovulate at least once compared to 25% on clomiphene. And when you use letrozole, they have a better fecundity per ovulated patients, telling that they have a better quality of ovulation. And then they also checked mid-luteal ovulation check, and they found that letrozole have a higher progesterone and a lower estradiol levels, which mimic physiological hormonal milieu than with clomiphene. Another study, letrozole, gonadotropin or clomiphene for unexplained fertility. So in this, of course, patients with gonadotropin had the best outcome, but then compared with clomiphene, letrozole was superior. What about metformin? So metformin is used to reduce insulin and androgen concentration and to treat anovulation associated with PCOS. So in whom should we use it? So you can add to persons metformin to be added to clomiphene citrate therapy in patients who are resistant to clomiphene, or you could add clomiphene citrate to those who have failed to ovulate on metformin alone. So when you do this, some of them will achieve ovulation and also pregnancy before you turn to FSH. So one of the main indications where you use it is in IVF to prevent hyper-ovarian stimulation syndrome. And then if suppose somebody has IGT, that's another place where you can continue to use metformin. 50% responders with regular menses by 6 months. Who are the responders? If you have a family history of type 2 diabetes, the BMI is more, who are having a higher androgen level, who had a rapid weight gain. So these are probably the responders with metformin. The third line include gonadotropins and laparoscopic ovarian drilling. I won't deal with this much because we don't practice this. What is the role for antioxidants? They have found that there's an increase in reactive oxygen species, which can lead to poor oocyte quality, and hence drugs like myoinositol, N-acetylcysteine, chromium, vitamin D has been tried, but then these are all not recommended. So the recommended ASHRM, ESHRE first line treatment for ovulation induction is clomiphene. But then now there is increasing evidence that letrozole is more efficacious and equally safe to mother and fetus. What is the second line intervention? Should be CC or a combination of metformin and CC if the first line therapy fails to result in pregnancy. The third line include exogenous gonadotropins or laparoscopic ovarian surgery. So I would like to conclude by telling that polycystic ovary syndrome is a predominant cause of anovulatory infertility. It's characterized by disordered gonadotropin secretion, hyperandrogenemia, insulin resistance, hyperinsulinemia, ovarian dysfunction, and follicular arrest. Ovarian folliculogenesis is dysregulated in PCOS, leading to infertility. First line is clomiphene citrate. Increasing evidence now that letrozole is more efficacious and equally safe to mother and fetus. Metformin can be used to prevent OHHS and in patients with IGT. Third line therapy is either exogenous gonadotropin or laparoscopic ovarian surgery. Thank you for patient hearing.
Thank you, Professor Ganapathy, for not only an excellent overview of the reasonably difficult topic, PCOS and sub-fertility, but also from an organizer's point of view, finishing well in time.